Please welcome Professor Kevin Chennar. Professor, please.
Thank you very much. It's a delight to be here. It's been snowing recently in London, so it's lovely to be in the sunshine, and thank you very much for inviting me. As a cardiologist, I'm going to have to tell you a little bit, to remind you a little bit about heart disease to see how testosterone fits in. The process of atherosclerosis is not really understood. We don't know what causes it, but it does cause a significant mortality and morbidity in the Western world particularly, accounting for 50% or so of deaths. Although we don't know what it's caused by, we do know some of the factors that are associated with its premature development, particularly smoking, and the other risk factors that you know about. Now, one or two things to say about risk factors. The first is that we can modify some of them. We can stop smoking, we can reduce cholesterol, control blood pressure, but we can't modify aging, or we can't alter the fact that men have twice the incidence of coronary heart disease than women do, and we can't alter our genetic background. Another important thing about risk factors is that they're not just additive, they're cumulative. This is data from a very large study of patients presenting with myocardial infarction of over 10,000 patients, and they looked at the risk factors associated with the development of infarct, and you can see the standard risk factors here: smoking, diabetes, hypertension. These are associated with myocardial infarction, we know that. But when you start adding risk factors together, there's an exponential increase in risk, and this is a logarithmic scale here. So from a risk of, say, 3 for smoking in this study, we get a risk of 16 when you add smoking to hypertension and diabetes. So when we combine risk factors, there's a worse effect. And this is the condition of the metabolic syndrome, where there is this classical combination of risk factors, including truncal adiposity, particularly visceral adiposity associated with hypertension, diabetes, and dyslipidemia. And this combination is associated with an excess cardiovascular risk. As we age, this is a normal morphological change of men that we see in the Western world. I want you to look at this diagram and recognize where you are. There's me. Some of you may be on one side or the other side, but you notice that there is a tendency to gain weight around the midriff with aging. Not surprisingly, therefore, the metabolic syndrome is age-related, and there's an increased incidence of metabolic syndrome in middle life, with almost 50% of men and women having characteristics of the metabolic syndrome by middle age. So where does testosterone fit in? This is all background, all stuff that you know about, but testosterone is a fundamental part of the metabolic syndrome. As we age, testosterone falls. It falls in women, we've heard that, it falls in men. But it's also associated with those factors associated with the metabolic syndrome. In this study, you can see the more factors of metabolic syndrome you had, the lower the level of the testosterone. In another study, in a urology outpatient clinic, they demonstrated exactly the same thing. So total testosterone was much lower the more elements of the metabolic syndrome you had. And if you looked at the relative risk of profound hypogonadism, clinical hypogonadism with a very low total testosterone level, then there was a tenfold risk if you had all the components of the metabolic syndrome. And I believe that testosterone in men particularly is a fundamental part of the metabolic syndrome, and it's strongly associated with weight. We've heard about the aromatase enzyme already, and this is in the lipid, particularly the visceral lipid in men, and it converts testosterone to estrogen. The estrogen is associated with estrogenization of the obese man with breast development and small gonads. So we know that adiposity will be associated with low testosterone. But in this study, which is really interesting, of the Massachusetts male aging study, non-obese men who actually had a low testosterone when they're followed up had a much higher frequency of developing metabolic syndrome. So it works both ways. If you have a low testosterone level, you tend to develop a eunuchoid habitus, which is the classical metabolic syndrome habitus. So, what about testosterone as a cardiovascular risk factor? Now, we've heard about androgen deprivation therapy. We've heard how important it is in treating prostate cancer. And in this study, looking at gonadotrophin receptor hormone antagonists and orchidectomy, there was a highly significant increased risk of diabetes and cardiovascular death in men treated with androgen deprivation therapy. These data are shown here. So in men without androgen deprivation therapy, this was the cardiovascular death. In ones with androgen deprivation therapy, there was a very significant increase in cardiovascular death. So that suggests creating hypogonadism is a bad thing from the cardiovascular point of view. Is there evidence, therefore, that atherosclerosis is promoted by or is associated with a low testosterone? Well, in a case control study that we did many years ago now, well, at least 10 years ago now anyway, looking at coronary angiograms, we studied men with definite coronary artery disease based on coronary angiographic findings and those with normal coronary angiograms whose angiograms were done predominantly for valvular heart disease. And we excluded factors which would be associated with suppression of the testosterone, so excluded previous MI and severe illness in the last 3 months, and we excluded anybody with a high PSA when we took the blood sample. And we used early morning blood samples because of the diurnal variation in testosterone. And we found that free testosterone and bioavailable testosterone were highly significantly lower in men with coronary disease compared with age-sex-matched controls. And they were all these data were corrected for the standard age, body mass index, and weight, and so on. So there did seem to be an association between low testosterone and coronary atherosclerosis. Another way of looking at the vascular tree is to look at the carotid artery, and you can use a measurement called intima media thickness from ultrasound scans of the carotid artery. And this is a marker of atherosclerosis. And these Finnish authors demonstrated that the lower the level of the testosterone, the higher the IMT, the intima media thickness was. More importantly, in this Dutch study, patients followed up over about 4 years. Those with lowest levels of testosterone had a much greater increase in the intima media thickness demonstrated by repeat ultrasound scanning in the carotid 4 years later. So this is the men with the lowest levels of testosterone, and they had the biggest increase in IMT. And it's particularly dramatic when you look at the free testosterone. Third vascular bed was studied by another group of Dutch researchers who looked at the aorta, and they simply did x-rays, lateral x-rays of the abdomen, and on those x-rays you can see calcified plaque in the aorta, and they measured the number of calcified plaques, and they followed people up for 7 years, and they did another x-ray, and they could see a dramatic increase in progression in the number of calcified plaques in those men who had lower levels of testosterone here. So that suggests, again, that a low level of testosterone is pro-atherogenic. There are animal studies showing exactly the same thing. We developed a testicular feminized mouse, which has an absent nuclear androgen receptor, but also has a deficiency in 17-alpha hydroxylase, so testosterone levels are about 10% of normal. And if you cholesterol feed these mice, then they develop lipid deposition in the aorta, which melts away when we replace their testosterone. So what about treatments? If men with coronary disease have low levels of testosterone, should we be treating them? Well, we did some more work on this before we started treating our men with testosterone, and we identified other non-genomic effects of testosterone. So far this morning, all we've talked about are genomic effects through the androgen receptor. But testosterone is a direct vasodilator. It has a receptor on the endothelium and vascular smooth muscle, and it causes vascular smooth muscle relaxation. And this effect is mediated by a calcium channel. And that calcium channel is the same one that is blocked by nifedipine in our work anyway. That's what we've shown. So testosterone is a calcium channel blocker, and calcium channel blockers are useful for angina, so we studied it in angina. But we weren't the first to study it in angina. Back in 1940s, testosterone extract or gonad testes extract were given to men with angina, and their angina got better. And our research was actually triggered by this paper by Wu, in 1993. It's a Chinese paper. We only had an English